Hi, everyone. I'm Bill Sappenfield, and I have the pleasure of directing the Florida Perinatal Quality Collaborative. And we're just going to give a couple more minutes to give everybody an opportunity to get on. We're so glad that you're with us today, and we're excited about unveiling some of the changes that we've made to this PQI indicator report and system so that you can learn the new ways that you can see the data from your hospital. Hi again, everybody. I'm Bill Sappenfield. I have the pleasure of being the director of the Florida Perinatal Quality Collaborative, and we're going to be presenting today an update on our Perinatal Quality Indicator project. Today's webinar actually serves two purposes. One, for all of you who are PQI users, this is to update you on your reporting system and all the information and options that are available to you. And two, for those of you involved in our Social Determinants of Health initiative, this is your chance to learn more about PQI and how we now have enhanced the reporting system to better help you address the social determinants of the women that you serve. And today is a chance for you to learn about our system, but we also want to hear back from you. Will this work? What do you like about it? What do you don't like about it? We want to make the PQI reporting system a tool for your hospital that serves the best use for you all where you are. Next slide. So today we're going to go over some background about the PQI and the context. We're going to give you an overview of the indicator report. We're going to talk about the DOH, the Social Determinants of Health dashboard, and identifying differences. We're going to go on to interpretation and actionable insights, and then we'll take questions and answers and then wrap up. Next slide. Again, we always start this because this is what's important. Our vision as the FPQC is that all Florida's mothers, infants, and families will have the best health outcomes possible through receiving respectful, equitable, high-quality, evidence-based perinatal care. We're voluntary, we're data-driven, we're population-based, we're evidence-based, equity-centered, and value-added. And our presentation today is about how we are data-driven. We want to provide back data to you about your hospital and how you're doing compared to others and over time. Next slide. Again, we couldn't do what we do without our partnership. The data sets we get come from our partners. The input we get into our initiatives and what we do for PQI come from our partners. We are definitely a collaborative. Next slide. So PQI supports hospital providing periodic hospital-specific reports on 9 different indicator sets, predominantly maternally related. And then we also talked about how the quality of your data is and whether you should have data concerns for your hospital as it relates to the report. The nice thing about this program is you don't have to submit any data from us. We get birth certificate data, hospital discharge data, and link data from state agencies that we can put together. And we base a lot of this with all the national efforts that are going on. We borrow from AIM, the Joint Commission, the National Quality Forum, as well as the Society of Maternal Fetal Medicine. Next slide. We have these 9 indicator sets. They're predominantly maternally related. Many of them come from national measure data sets. In fact, we'll relate to you here. We look at non-medically indicated early term deliveries, PCO1. We look at low-risk cesareans, nulliparous term singleton vertex deliveries, POC2. We focus on an NTSV comparative measure where you can see how you're doing with Joint Commission versus Society of Maternal Medicine. We focus on field induction of labor. We have severe maternal morbidity, unexpected complications of the term newborn, severe hypertension preeclampsia, obstetric hemorrhage, and neonatal abstinence syndrome.
Bye.
Next slide. So what are these indicators for? They're one, to help you all monitor and improve for infant health outcomes. Again, whenever you identify variations, is that an opportunity for improvement? We do want to promote fair and equitable access and quality for all, so that you can look to see if there are population differences in the women and infants that you serve. It's to help you guide your quality improvement initiatives and what you're doing within your hospital. And it's help inform and policy and resource allocation. Again, we're trying to design this for you all, and your feedback back interactively is very helpful in telling us what we need to do and how should we provide it. Next slide. Just so that you know that the data that we provide is high quality and recognized nationally. We have now 5 publications already published out using these indicators at a hospital level to address and identify various issues, and we're about ready to have a 6th one. So if you're wondering about, is the information we provide credible, it's incredible, it's credible at multiple levels. Next slide.
Good afternoon, everybody. My name is Benjamin Gessner. I'm a data analyst here at the FPQC, and today I will take us through some of our data sources, as well as some of the different parts of the PQI report. So as we see here, at the top of the page, you will see a hospital code. This code is very specific to your facility. You will become familiar with this code throughout the course of being in PQI. If you ever get a code that you are not familiar with, please reach out to us and we will correct this immediately. As well, our first data source that we get data from is the birth certificate. Now we have a 1-month lag on this, and the metric that we do through the birth certificate would be your low-risk cesarean deliveries. Our second data source is our inpatient hospital discharge data. Now we have a 6-month lag on this, and we currently have data through Q3 of 2022. The metrics through this are neonatal abstinence syndrome, severe maternal morbidity, which excludes blood transfusions, severe hypertension and preeclampsia, and obstetric hemorrhage. Our third data source would be the linked birth certificate and hospital discharge file. This is on an 18-month lag. This links the birth certificate to the hospital discharge data, and the metrics that we get from this are non-medically indicated early term deliveries, induction of labor and failed inductions of labor, comparative NTSV cesareans, and unexpected complications of the newborn. Through this summary page, if you ever want to go to one of these specific metrics, if you click on any of these metrics, it will take you directly to that page. And it's a very easy way to look at this summary page and then go to the individual metrics that you're concerned with. The different sections in PQI are the data quality dashboard, hospital profile, summary dashboard, SDOH dashboard, and indicator specific and supporting graphs. In these graphs, there's variation, quartiles, time trends, and disaggregation. The first portion of the data quality dashboard that we want to go over is the page that goes over the over-reporting of unknown variables. So the percent of unknown or missing in the birth certificate. If you have less than or equal to 1% of unknown, it will be shaded green. Between 1.1 and 4.9% unknown will be shaded yellow, and greater than or equal to 5% unknown will be shaded red. As we look here, we can focus on how we're doing with reporting unknown over time. So as you see, as we went through BMI, for instance, in 2020, we were green, so less than 1% unknown. In 2021 and 2022, we had more than 5% unknown, so shaded red. And here in 2023, we have in between 1.1 to 4.9% unknown, so it is shaded yellow. So we're able to track over time how you're doing with this reporting and see if the changes that you might be making in education with your birth certificate clerks might be working. The second portion of the data quality dashboard that we want to go over is the percent agreement in the link file. Now, this data just goes over whether the birth certificate data agrees with the data reported in the inpatient hospital discharge. This comes from the linked file, and we're able to go here and look at how we do over time with the percent agreement. So again, with the legend, if you have greater than or equal to 95% agreement, you'd be shaded green. Between 90 and 95% agreement would be shaded yellow, and less than or equal to 90% would be shaded red. In the instance of looking at some of your maternal characteristics, such as maternal race and maternal ethnicity, we can see here that in 2021, we did have some issues with agreement at this specific hospital. Here at the FPQC, we offer birth certificate training for all the hospitals in the state of Florida. So if you're having any issues, or maybe you have a new birth certificate clerk and you're a little bit concerned about the percent of agreement, we do offer that training to all of the birth certificate clerks in the state of Florida to help improve the data quality. The higher the data quality, the more powerful the data that we'll give you through PQI really will be. The next section would be your hospital profile. Here, we just wanted to go over one of the graphs that you'll see in your hospital profile and see how it applies to your PQI report. So here we go over maternal race and ethnicity, and you're able to look at your hospital versus Florida hospitals and the distribution of the population that you serve. So as we see here, Hospital X serves a higher percentage of non-Hispanic Black and Hispanic individuals compared to all Florida hospitals. So you're able to use this and kind of look at change plans and see how you can better fit that population that you're serving. The next portion would be the hospital profile elements, still in the same section. Here, we just want to go over the individual elements that we do give you: maternal race and ethnicity, payer, maternal age, maternal education, prior live births, fetal presentation, method of delivery, pre-pregnancy BMI, gestational age, birth weight distributions, and multiple gestations. So here on the right, you'll see these slicers. So you're able to go through and click on the individual years to see how the distribution might be changing. Again, this would be an indicator if you have seen a normal distribution throughout past years, and suddenly there's a change in maternal age or payer or pre-pregnancy BMI. This could be an issue with the birth certificate recording. And again, we do offer that training. As we look down at pre-pregnancy BMI, we see that your hospital has a slightly higher percentage of unknown than Florida hospitals. So that would definitely be an area of interest to look into in the future. The next section would be your summary profile. Now, this page is just a snapshot of your PQI report for you to look at. You're able to look at different key perinatal indicators, the last 12 months of available data, which you'll be able to compare yourself against the state of Florida average, your hospital's percentage, and whether or not there is a data quality issue. Again, we offer the stratifications on the right-hand side: NICU level, race, ethnicity, payer, and education. So if we go into percent of non-medically indicated early term deliveries, we see in the last 12 months of available data that Hospital X is in the lowest 25% of hospitals, and that its percentage is 12.5%. We also see that there is a red flag up for agreement, which means in this file with that statistic, there is an agreement issue, but there is not an unknown issue within the birth certificate data. And with that, I will pass it back to Dr. Rubio.
Thank you, Ben. Good afternoon, everyone. Welcome, and thank you for joining us. So in line with what we are discussing, we wanted to give you a quick background of PQI. A lot of new hospitals have joined, and so we wanted to have everyone know the several sections that are available to you. And now we're going to go on the section that we have enhanced, that we have added for you all, and you're going to start receiving with the next batch of reports that are coming out to you next week. So when you are looking at SDOH, there's two ways that you can look at it. You can look across outcomes, and you're going to examine differences by SDOH, where the dashboard that I'm going to share with you is going to come very handy, because you're going to look at all the indicators and you're going to focus on the differences by SDOH. But you can also look within an outcome. And so the second section of graphs that I'm going to show you are going to help you with that, where you're going to be able to examine the differences by SDOH within an outcome. So let's start with the dashboard across outcomes, right? Let's see. So the dashboard is quite extensive and busy. And so we are breaking it up so we can discuss it and you can see exactly what we want you to look at. This graph is the type of graph that is added in the dashboard. You're going to have the distribution of the rate by a patient characteristic. So in this example, you have race ethnicity, and we have 3 main groups in Florida that are representative enough to be included in the disaggregation. So you have non-Hispanic white, non-Hispanic Black, and Hispanic. We have used different figures, so whenever they overlap, you will still be able to see where the rate is for that particular group. And we have added 2 lines so you can compare yourself with others, right? So the bold line is the state average, and the dashed line is the hospital percent. So immediately you know that for this particular indicator, the rate of the hospital is higher than the average of the state. So immediately you know there is a problem here, right? And then when you look at the disaggregation, you can see the gap between Hispanic and non-Hispanic white versus non-Hispanic Black. There's a big gap. We also provide you the ratios so you can actually see the magnitude, how much and how important that gap is. And so within the graph, we want to point out a couple of things to you. The first one is that the graph is zeroed at the left. And we did that so all the graphs are going to be comparable across the dashboard on the left axis. However, the axis is dynamic. So you're going to see that on the right, that's going to change. For some indicators, it's going to be 10%. For others, it's going to be way more. And that is dynamically adjusted so you can see the difference better. And the graph makes sense, because otherwise you're going to have a very slammed portrait of the gap. So that's something that you need to keep in mind. Please always check your axis to look at the correct values. The next thing is what I mentioned to you. We are providing ratios, and we have made a conditional formatting within the graph that if the ratio is more than 1.5, you are going to get the number highlighted. So it's going to be more visually attractive, right? You're going to be, your eyes are going to be drawn to it faster. But you may decide that 1.5 is not an acceptable benchmark, and you may want to see at lower ratios because any disparity is a disparity, right? So again, pay attention to your ratios that are going to be provided next to each graph. So here's another example for a different indicator, right? This is an NTSB low-risk cesareans. This comes from the birth certificate. So we have also added the source where the indicator comes from, and you have your ratios. So in this case, you have the non-Hispanic Blacks have a ratio of 1.5 compared with the reference group, which is non-Hispanic white. The reference group is always fixed, and that is going to be 1, right? So it's a 1.2 to 1 ratio. And when you look at the definition, what you can quickly say is that non-Hispanic Black women have a 20% higher likelihood of undergoing a cesarean section in this particular hospital compared to non-Hispanic white women. So this type of phrases is something that we want you to start practicing and start building for your particular case. If you identify a gap in service, a gap in quality, or a gap in the perinatal quality indicators, it's important that you can state it in a statement, a quick statement that you can share with leadership, that you can start to bring awareness. So now you know each one of those graphs, what it means and what they tell you. So in the dashboard, you're going to have a collection of all the perinatal indicators, and you're going to see that disaggregation by race ethnicity. If you want to see it by insurance, you only have to click on insurance, right? Click on insurance, and you will get the data disaggregated by the 2 main groups, either Medicaid or private. So here for this particular example, you can see that those shifted, and there is not a lot of disparities. The biggest one that brings your attention is neonatal abstinence syndrome, right? You also have education and BMI. And so once you access your report online, you will be able to click on those slicers and get access to the adequate report. The reason why we did it on a dashboard is because we do have 9 key perinatal indicators. Unexpected complications of the newborn are divided into severe and moderate, so you have 10 in total here. We want you to be able to share this quickly with your leadership, and we know that if we give you way too many pages, it's going to be more difficult than if you have 1. So hopefully this summary, this dashboard of the conditions by the patient characteristics are going to be useful for you when you have these discussions with your leadership. Okay, we're gonna stop for a second and take any questions you may have. Either raise your hand, come out of mute, or you can drop it in the chat box. We just want to check with you that what we have been covering till now has been is being well received, or if you have suggestions, questions, anything that you would like to add.
Stephanie, this is Nell from Bethesda.
Hi, Mel.
Hi, how are you? I have a question about the early term pregnancy induction. What are the parameters with that? How many weeks? Can you go back on I think it's the last slide that you.
Sure. So I am happy to take the question, but today, now we're just going to go through the sections of the PQI report. For any specifics, I'm more than happy to provide to you the actual methodology of how it's calculated. And, you know, because we have a description for every single one of them. And that's an excellent question, actually, for others. If you have questions about any indicator and how it's measured and the specific conditions of each measure, we have the anatomy of the indicator. So it will tell you the definition, and then we do give you the codes or the conditions that you need to take into account when calculating that particular indicator. So let me see, you were asking me about
the non-medically indicated early term deliveries.
The cutoff for early term is 39 weeks.
39. Okay, so from 37 to 39, those weeks?
Those would be considered early term.
Yeah, okay. Thank you.
No problem at all.
Be clear though, this is a surrogate measure. It will not line up with the measure that you submit nationally, because you do that by clinical chart audit. But this tries to look at it by various risk factors. The reason we do this is the rate is a little bit higher. But if this rate is substantially higher compared to other hospitals, you may want to look over your method on how you're abstracting records, because this is an indication that you have some patterns that are different than other hospitals in this group. So just say again, this will not line up with what you submit nationally, but you do that by audit. This is trying to do this by medical record.
Correct. The other thing we have seen is that gestational age, I'm sorry, lapse there. Gestational age is not very well captured in the inpatient hospital discharge data set. It's better captured in the birth certificate. So again, if you find that there is a lot of differences between what you are capturing in the medical record abstraction versus what we give you, that may be an opportunity to improve the quality of your inpatient hospital data, which is what your hospital reports to the Agency for Healthcare Administration as part of claims data. So yeah, just a note. So there's another question in the chat. It says, how do we access the dashboard? Within the next weeks, Ben and I are going to be working with you all to give you access to the online report. Basically, you have to go through a process to secure a USF guest account. You will give us some information about yourselves. So your name, your date of birth. We asked you to provide your cell phone because we have to do double authentication with USF to create your account. But once we put that in the system, we create that guest account for you and you can access the report. The thing is that we want to keep your data safe. That is our promise to you. And so the only way to access the report is through that password protected account. And so in the next weeks, if you don't have one, because many of you already have one. So if you already have one, Ben and I will give you access in the next week to your report. But if you don't have a guest account, then we will create one for you.
And for those who do not want to do it electronically, we do produce a PDF version of that, but you do not get the full spectrum of all the different measures. You get a limited data set. So again, we have a backup option for those who don't want to go online, but you get a lot more information and a lot more robustly if you go online.
Absolutely. There's another question that says, can you go back to the slide with the flag unknown? Please explain the flag again. So it was very important for us to work on the quality of the data because, you know, the report has more value if we can trust the data. And when you share it to your providers and leadership, it's going to be stronger if your quality is good. And so we wanted to keep telling you where there are issues, right? And so we're using a flag and a check mark. And so unknowns, it comes from the birth certificate mostly. So if you are reporting a lot of unknowns and that variable is utilized to calculate the measure or the indicator, then you're going to get a flag. If there's no issues, then you get a check mark. Agreement is between the birth certificate and the inpatient hospital discharge. So for example, early term deliveries, we do utilize some of the data comes from the inpatient hospital discharge and some comes from the birth certificate. And so if there is issues between the agreement, for example, for gestational age between the two, we want you to be aware that there is an agreement issue. And so that is just an invitation to look at those issues and work on them with your group, with your team. There is another question. It says, if we have access for, say, the PAC data already, do we need to set a separate account for SDOH? We have a different manager working as the data collector, just wondering if we are going to use same account or separate ones. So if you have an account, you don't need a different account for each report. If you have access, if you have the USF password protected account, we can give you access to all the reports for which you are the liaison or the lead, right? So if you are the lead for PAC and the liaison for SDOH, then you will have access to both reports through the same USF account. If there is multiple people, we try to keep it to a maximum of 3. But we can always work with you. If there's more people that need access, please reach out to us. We're more than happy to work with you. We would prefer to keep it at 3, but we're happy to make exceptions if there is a reason for it.
Part of the rationale behind that, just that you understand, is this is a highly secured data system so that nobody can break in, hack in, and see your data. The challenge with that is if you don't know your password and it needs to be reset, the university is going to require you to prove who you are. In other words, it's not some simple confidentiality questions you ask and you get a new password. They're going to really want to document that you literally are who you are, which is a painful process. So the reason we try to limit the number of people is so that people can keep up with the passwords and not have to go through that challenging process.
All right. Okay, I don't see any more questions. Do we have any raised hands? Any other questions?
Alexis just asked, would the suggested access members be the project main contact and PQI contact for each hospital?
That's exactly right. We are hoping that the people that have access will be the ones leading the projects. So yes, your initiative lead would be the best person to have access to it. And the idea is that, one person will have access, and whenever you meet as a team, you can share and you can, get those insights together as a team, as a group. Not everyone needs access to the report if you all get together and look at it together. And the initiative lead will also be able to print a report or just share the PDF that we share with you all. So the interactive features of the online report are meant to give you additional insights, but it definitely should be to the person that is leading the project that has the most influence. Okay, all right, I don't see any more questions. Do we have any more unanswered? No, okay. We can move forward. So I was telling you that there is 2 ways that you can approach looking at SDOH. One is across outcomes using the whole dashboard. The other one is looking within an outcome and examining the differences by SDOH. And so for that, we're going to use a different set of graphs that are also available in your report. So here you have our usual color-coded box plot, quartiles, graph that you have been receiving for a long time if you have been PQI for a while. Otherwise, this is a new graph for you. Let me just briefly explain to you. So this is the rates. In black, you're going to see your hospital rate. And the idea is that you're going to see this over time. This is yearly, but you have access to this data quarterly and monthly. So it will be depending on what you want to see, you can choose how often you want to see the time trend. In this example, it's just yearly. So in black, your hospital rate. Now, in this type of graph, we really want you to compare your hospital rates to others in the state. And so we have 106 maternity hospitals in the state. We rank their rates from higher to lower, and then we divide them in 4 groups. So you're going to have 25% of hospitals in green, with the lowest rates, 25% of hospitals up in red with the highest rates, and then 25% above and below the median, right? So 50% in the middle. So for this particular hospital, if you would like to know how well are we doing, okay, in 2018, we were right in the border. In 2019, this particular hospital worked really hard at in decreasing their NTSB cesarean rates, and they did fantastic progress. They went down, and they were one of the hospitals with the lowest rates, right? And then COVID hit, and they were really, really impacted, and their rates went back up again. And now they are among those hospitals that are above the median. The green line is the median, and in that 3rd quartile. And so they can see their progression over time, and they can start to figure out their issues. So they have definitely seen a regression, and there is something that they would like to start exploring. So once they see that that's something they want to explore, they may want to see only compared to NICUs that are the same as MARI hospitals. So you can just click your NICU level, and the graph will get readjusted to only include hospitals that are the same NICU level. And so here you can see that, okay, we still have a problem, right? Not as bad as before, but we still have a problem. We are among the hospitals that are very close to the mean, and we have seen a regression over time. From there, you would like to know maybe how your different groups are performing, right? If you have differences by group. So you can disaggregate your rates by these graphs that we're providing now. And you're going to see the time trend again. And please pay attention to the axis of the graphs, because again, I'm sorry, those are dynamic. And you're going to have your legend. So for this particular variable, which is race ethnicity, you're going to have 3 groups: Hispanic, non-Hispanic Black, and non-Hispanic White. You see that when quality improvement works, it works fantastic. They went down in 2019, and the gap between their groups really smashed. Like, it was very, very small. But over time, when they saw the regression, you can see that the gap starts to widen again. And in 2023, they seem to have a very, very important issue with their non-Hispanic Black population, right? You can see that huge spike. So when I look at this huge spike, and that's something that I hope you're also thinking about, the first thing that came to my mind is this a data collection error, right? So I went back and checked. No, it wasn't, unfortunately. So then you can move on to see, okay, what other disparities are there? For if whenever you get access to the online report, you can just check in the slicer insurance. And so for insurance, we have 2 main groups, Medicaid and private. And for this particular hospital, there's not much variation over the years, but this 2023, there seems to be a gap that is widening, right? With private insurance patients having higher likelihood of NTSB cesareans. You can also click on education. For education, we also have 3 groups. So you're going to have patients that had less than high school education, patients that have some high school education or some college, and those that have bachelor's degrees or more. And here we tend to see that people that have more education tend to have more cesareans. And you can see that at least for 2023, that is not true, because again, we have this huge uptake on this particular rate, right? The percent of women that had an NTSB cesarean and that had less than high school. So again, here, the first thing I thought is this a data error? And I went back to see their hospital profile. And that's something that I invite you to do every time. If you have a question about why is there such a huge change and does it make sense, try to use the different sections that we went over today in your PQI report. The hospital profile is one of them. So when I looked at the population distribution, this particular hospital had an increase in 2023 of the percent of patients that were less than 20. So the fact that they had less than high school education is more likely, right? So just a quick check with your own report that you can get additional insights. And if that doesn't match, if that's not the case, then maybe that's something that you need to review with your birth certificate clerks and see if they are collecting the data correctly. But other than that, that's how you would look your disaggregated measures. And then the last one is BMI. So we have, again, 3 groups. A BMI of less than 30, so that would be normal weight and overweight. BMI between 30 and 34, that's obesity class 1, and then BMI for 35 or more, which is obesity class 2 and 3. So you can see that the NTSB cesarean rates for the BMI 35 plus or obesity class 2 and 3 are the highest, but for those that are normal weight or overweight, that rate is going up. Right. So again, something that is not among the highest rates, but it's going up. So it's something that should start to ring red flags up. All right. So those are the pieces of the graphs. This is how you're going to look at how it's going to look in your PQI report. You're going to have your time trend graph with the comparisons in the back for the quartiles. So you can see how you compare over time. You're going to have your measure disaggregated by race ethnicity, and you have here your slicer, so you can click on insurance, education, and BMI, depending on which one you want to disaggregate for. You're going to have your hospital table where we're going to give you all the numbers for the rate. And if you click on a particular group, then that is going to be adjusted as well. And you're going to be able to see the number of patients under each category. And you also, as always, have your data quality issue flag and check mark just to double check that you have that in mind and that you work on improving the quality of your data if you have issues. As I was mentioning before, you can also look at specific groups within your categories. So for example, race ethnicity, you have 3 groups: Hispanic, non-Hispanic, and non-Hispanic Black, and non-Hispanic White, right? If you wanted to only see for non-Hispanic Black, you can click on non-Hispanic Black in the legend right here, and the whole graph gets readjusted. So you can see now that this particular hospital has one of the highest NTSB cesarean rates for non-Hispanic Blacks in the state. It's in the red. It's well above the median, which is the blue line for Florida. And, you know, if they wanted to see the actual numbers, because in some places you may think we don't have such a large population, and that may be the reason why the rates is so high, you're also going to have access to the particular numbers in this section. Right now they're white out because we don't want to give you specific hospital numbers, but this is where you would find your numbers to check for a sample enough that you can compare across. But yeah, this is how you would be able to get particular numbers and specific graphs for a group within a characteristic. So again, if you wanted to see a BMI only for obese class 2 or 3, you would click on the slicer where it says disaggregated by, you would click BMI, and then you would go to the legend and you would click obese 2, 3, right? And then you would get the whole graph adjusted for that particular group. So today we wanted to show you how you can use PQI for SDOH, correct? So we had mentioned before that it's very important that you understand the population that is being served. And so one of the reasons we developed the hospital profile is to help you with that. We want to be sure that you monitor improvement over time. And that's why we have all those time trend graphs. We want to make sure that you're able to make cross-institutional comparisons to detect variations in quality of care between entities serving similar populations. And again, that's the reason why we have the color-coded quartile graph, so you can actually see how you compare across institutions in the state. So we are, checking a couple of the things out that you are going to be able to access through PQI. When we were looking at the framework, again, the first step was detecting. So you're going to be able to measure the differences in vulnerable populations through your PQI report. Now, your team will have to work on several other things like defining health disparities within your unit and what it means to you to define vulnerable populations depending on your communities and to consider selection effects and other factors that may be impacting those SDOH. We had talked about examples of potential interventions, and this is just an example, depending on what you find, you may want to implement a cultural competency training. You may want to do language and literacy service enhancement. You may want to restructure care team or department teams. So again, these are just examples. Right now, the first step is going to be access your report, try to find the insights of the report, what you're going to focus on, what's going to be your population. If you are already working on an indicator, then perfect. Just look at your disaggregated measures and see where you have bigger opportunities. If you are not, then you would have to select an indicator that you want to work on and then address that disparity. And then once you know what you want to work on, we will tailor those interventions. And, every single month we're going to meet for the next 18 months in the coaching calls, and we will talk about strategies and ways that you can do that. We really hope that once you define those things and you select your indicators and your vulnerable populations, you will share that with us in the coaching calls so that we can learn from each other. So your next steps for SDOH, one, and for PQI as well, if you are not part of SDOH, is to, one, identify that healthcare disparity, as I mentioned, and the specific population, and then to set the improvement goal. So as you saw in the graphs, you're going to have a lot of potential benchmarks, right? You have the Florida average, you have the quartiles, so you have the 75th percentile that you could use as a benchmark for the improvement goal. You also have your historical trends, so you can see what is doable, what you can actually achieve. So use those things to state your improvement goal and what you can do with your teams. So that's something that we ask you to do once you have access to your PQI report. And then during the coaching calls and through the year, the 18 months of the initiative, we're going to work on the last two, which are the strategies and resources needed to achieve that goal, and the process that will be used over time to monitor and report progress. Okay, we're going to stop again and we're going to take questions. I see, Jennifer, you have your hand raised. Go ahead.
Yeah, so my question is, the couple slides back where you had the flags, I know you went over it with the previous section. Could you go back to that? So when we're looking at that on our report, it's two ways to verify if the data is good, correct?
Mm-hmm.
And so if it isn't, are they a different color? Are they absent? Like, does the check become an X? Like, what does that look like if the quality data isn't good?
So you're always going to have a red flag if it's a problem.
Okay.
And if it's not a problem, it's just going to be the check mark. So once you fix this problem, for example, this flag is going to become a check mark.
Okay, thank you.
No worries at all. My pleasure. Okay, let me see. Ben, do we have any questions in the chat?
Not that I can see.
Okay. All right. Any other questions? Anything else that you would like us to clarify so far? Okay. All right. So this is our last slide. You are now part of PQI. And one of the things that we ask you to do is to always have an assigned PQI contact. If that person leaves your hospital or there's any change, please let us know. It's very important that we keep the right person in our contact list so we can provide the right access and also the right reports. If there is a change in your PQI contact, we ask that they complete the training requirements as you did, and that you participate in 2 short surveys per year. The first survey of this year went out 2 weeks ago, I believe. Dr. Linda Detman sent it to you all. So please make sure to complete it. Once those surveys are completed, we will give you access to your PQI report. We usually send one around this time of the year, and then the other one goes around the fall. So please, it's just a very short survey asking you about many topics that are relevant to the current state of healthcare. So this time around, we was focused on capacity. We want to see how well you're working with the staff that you have and the issues that you may have. So please be sure to complete your survey. Once you have access, we do ask you to review your PQI report at least quarterly. You may do more often, but we ask you to review at least quarterly. And then to always focus on promoting a quality improvement effort with the data insights that you get from your report. We are very happy to announce that now we have 97 hospitals participating in PQI out of the 106 hospitals in the state. So, we just have a few that are completing training. So very soon, I think we're going to have 100% participation. And the good thing is that PQI does count as one of the initiatives for meeting the state statute of participating with FPQC. So, you have one of the two that the state statute requires. But more than that, we really hope that the report is valuable to you, that you have the bandwidth. I know that right now teams are very busy, but that you have the bandwidth to review it, to, interact with it, to try to get those little pieces of information that are going to help you build your case to work on SDOH and improving the health for all your patients. And if there is any ideas or any suggestions that you have, please never hesitate to contact the FPQC team. We're here for you. We can connect very quickly through Zoom. Our email is fpqc@usf.edu. You can shoot us an email anytime. Those are our social media platforms, but we are an email away and we're always willing and happy to help you any way we can. So that's all we had for you. Do we have any other questions pending? Let me see.
Tracy had asked, how do we dive into the problem with data quality?
Okay, so data quality is something you will have to explore with your team. That's a very in-house kind of problem, right? Because it's a lot of how you collect your data. When we were presenting data insights as a driver in the SDOH meeting, one of the things we found is that people may not feel comfortable asking questions. So for example, when we were looking at the quality of race and ethnicity and language and education, one of the biggest things that came out is that the people that collect the information don't feel comfortable collecting that information. So if that's the case, you may need to provide additional training to your staff, and you may need to do role play on asking those questions so they feel more comfortable over time. It may be that, they need additional training of why that is important. And that's something that we touch on in the birth certificate training. We have gotten a lot of comments saying that they have been working as a birth certificate clerk, for example, for a very long time, and that they never heard how that data is utilized and why it's important. So sometimes, quality data diminishes if the correct training is not provided, if people don't know why that data is being collected. If people think that that data is going to go into a repository, nobody's going to see it ever again, why put the effort, right? But this data is highly utilized. And so we need to make sure that people that are collecting that information know it. And the other thing is standardizing your processes. In the electronic medical record, there is a million places where you can put one thing. And so making sure that there's no duplication, getting rid of those spaces that just bring redundancy, and just standardizing how you document that information is important.
Again, a lot of it will depend on what's causing your data issue. If it's on the hospital discharge side, that's going to be definitely more of a training issue. If it's race and ethnicity, it tends to be more on the hospital discharge side. And so it goes back to how do you make sure you collect that correctly when mothers come into the hospital, and make sure you're doing that correctly and people are well trained. If the issue is related to your cesarean rates being underreported, or that you're having problems with vertex deliveries, that's on your birth certificate side. Do know on the birth certificate side, that FPQC and the Florida Department of Health Vital Statistics would be very willing to work with you and help you on improving the quality of that reporting. And if you're unsure what the issue is, please don't hesitate to reach out to Stephanie and Benjamin, and we're happy to coach you through it, because we as you want to have you all have quality data, because that's how we all can work together to improve healthcare.
Absolutely. We did have a couple of questions about the slide deck. Yes, it will be available. We'll send it out via email to all the participants, and then it will also be posted in our FPQC website.
Again, many of you have been asking about the survey. If you didn't get the survey, if you're the PQI contact, email us at fpqc.usf, fpqc@usf.edu, and we can follow up with you. It may have gone to spam, but we can make sure you get the survey. And again, if you haven't done the training yet, you won't get the survey, because we need to get you qualified first.
Perfect. I don't see any other questions. Okay.
Again,
let's
this
see
is
if
a
we have-
hospital tool for you all. We want it to work. We want it to be assistance. We are here to help. This is all able to be improved and changed. So please let us know what's working, what's not working, what can help, and how we can be of assistance.
Jody, you sent out, how do you get qualified? Can you please tell us what you refer to? I'm not sure I followed the question.
That's related to the training. If you go
Okay.
on the website, you're signing up, there are training videos that are there. There are simple tests that you take with it. It basically shows that you know how to read the reports. And so that you know how to make them make sense. They're very short, they're very simple, but you have to go through those tests as part of your qualifying piece, and that completes your application to PQI. And then we can start sending you survey and reports.
Perfect. Okay, I don't see any more questions. As Dr. Sappenfield mentioned, this is a tool for you. Let us know your feedback. It's very important to us. We take it into consideration. Sometimes when I go to trainings with SDOH, I always complain that I don't get a tool that I can walk out with. So we were trying to address that. We are trying to give you a tool that can be very useful in assessing disparities and differences within your population. So let us know if you have any issues accessing, and Ben and I will give you access within the next 2 weeks that the next batch is coming out. So yeah, if you have completed your survey and you haven't received your report within the next week, let us know. And with that, I think we're done. Thank you so very much all for your participation.
Thank you all.
We're giving you back 5 minutes of your day. Have a wonderful day.
Thank you.
Thank you.
Thank you.